How's it going, guys? We have a pass-level question for renal. We have a 61-year-old woman with chronic kidney disease. Creatinine is 4.1, should be 0.7 to 1.2. Once you've hit a creatinine of 2, you've lost 90% of your renal function. Blood urine nitrogen is 71, should be under 20. What's most likely to be seen in this patient? Choice A, anion gap of 12 is wrong. So a normal anion gap is 8 to 12. 13 or greater is considered increased. Uremia means renal failure. Don't confuse it with hyperuricemia. It's completely unrelated. So we'd say this patient has uremia, which is the syndrome of kidney failure. And U for uremia, that's in mud piles, the mnemonic for high anion gap metabolic acidosis, methanol, uremia, renal failure, DKA, fenformin, weird drug you don't have to know, / propylene glycol, isoniazid, iron tablets, lactic acidosis, ethylene glycol, which is antifreeze, salicylates, which is aspirin. So even if you're not sure what's going on, we don't have the values to calculate anion gap here, you know that because it's uremia for renal failure, it's part of mud piles, so it would have to be 13 or greater. So to calculate anion gap, you're going to take chloride and bicarb, you add them together, you take that number, and you simply subtract it from sodium. So it'd be 13 or greater in this case. Choice A, wrong fucking answer. Choice B, bicarbonate 28 is fucking wrong because normal range 22 to 28. And if you have a high anion gap metabolic acidosis, you would expect bicarb under 22. Now, it should be explicated that you have to use your head and be able to lateralize and understand that not every single question must you have a low bicarb. Maybe you'll get a question with renal failure and the bicarb's 23. And you're like, well, it's not technically low. You're right. Okay, but 28 is definitely upper end of normal, which you're not going to see in renal failure. Okay, so it's simply that it's two main mechanisms. One, the kidney's not going to be able to reabsorb bicarb in the PCT the way it's supposed to. The second thing is that we normally secrete protons at the cortical collecting duct under the action of aldosterone. You can't do that the way you're supposed to. So you're going to be retaining protons, not reabsorbing your bicarbonate, and you're going to have decreased serum pH. Choice B, wrong fucking answer. Choice C, increased hydroxylase activity is wrong. So pretty simple that obviously you've got 1-alpha hydroxylase in the PCT under the action of parathyroid hormone that in the setting of renal disease would be compromised. Okay, so PTH can't do its job the way it's supposed to in the kidney. So you're not going to get the conversion of 25 inactive into 125 active D3 the way you're supposed to. So because you have less active 125 D3, that normally goes to the small bowel to increase calcium and phosphate absorption. Since you can't do that, you're going to get hypocalcemia, decreased negative feedback at the calcium sensing receptors, the parathyroid glands, and PTH goes up to compensate. It's called secondary hyperparathyroidism. Choice C, wrong fucking answer. Choice D, increased stomach vascular resistance, correct answer. Now, even if you weren't sure of the exact mechanism, some of you eliminated to get there. You could basically say that in the setting of renal disease, non-specifically in terms of a diagnosis, that you're going to get increased renin-angiotensin aldosterone system activation, increased RAS. So increase renin, increase angiotensin 1, increase angiotensin 2, and that not only is going to increase aldosterone synthase activity in the zona glomerulosa of the adrenal cortex, but angiotensin 2 is also a potent vasoconstrictor on systemic arterioles, increasing afterload, in addition to being a potent vasoconstrictor on the efferent arterioles leaving the kidney, normally increasing your filtration fraction. So patients who have renal disease, they're going to have increased afterload and increased preload. It's enough arrow for both. Okay, so you got increased RAS, so increased angiotensin 2, you got increased aldosterone. It doesn't mean the patient has hyperaldosteronism, no. We're talking about increase relative to baseline if the patient didn't have kidney disease. That's what the NBME wants. So let's just whip through the final one here. Potassium at 4 is wrong. Now, Normal range 3.5 to 5. And in renal failure, potassium is always going to be elevated. 19 out of 20 times it's elevated. Okay, so even if you say, well, couldn't it technically be normal in some patients? Maybe, but D is clearly right. Okay, so you are not able to secrete it the way you're supposed to at the cortical collecting duct of the kidney, in addition to not being able to filter it the way you're supposed to. So the electrolytes for renal failure, sodium can be variable, up, down, no change. Sodium can be variable, but potassium is always going to be elevated. Bicarb is going to be low. Calcium is going to be low. Phosphate is going to be up. Bicarb is going to be low. pH will be low. And anion gap is going to be increased. Wrong fucking answer.